Great. Thank you so much. This is so nice to see so many here. And thanks for those who joined online. And yeah, to begin, we acknowledge the land we are on, Gadigal land of Euro Nation, and it's never been ceded, and it's always been, always will be Aboriginal land. And as I was just telling Bridget, like I want you to talk more and then have a conversation more. So I'll keep the introduction very short. That is, hi Bridget, here you go, start.
Thank you. It's an enormous pleasure to be here. Thank you for having me. What I'm going to be presenting to you today is something of a reflection, and it's a reflection about values, evidence, ethics, policy. So I hope that you are going to find it food for thought. To give you some, oh, sorry, I'll just get my slide moving. Oh, sorry, that's the important part where the blood swirls out. We don't want to miss that. And I also want to acknowledge the traditional custodians of the land and acknowledge their ongoing care for land, air and water. So the big question that I started with in putting together this presentation is how are blood donation rules made fair and equitable? And to give you my context here, I've been involved in partnership grants with with what's now known as Lifeblood for about the past 7 or 8 years. So it's an ongoing kind of partnership. And what we are looking to do is to do the research around changing, around increasing blood donation in a variety of ways and providing the evidence that is needed, and also doing some of the community work to see what is and what is not acceptable. And I'll talk to you, but that is not where I first started working around blood donation. In fact, I'll be talking as I present this back to 1999 when I was working for a community organisation, the Australian Federation of AIDS Organisations. But we'll get to that as we go. So my overview. I'm going to be talking to you about the history of blood donation deferrals with respect to gay, bisexual and other men who have sex with men, and trans and gender diverse people. I had initially flagged that I was going to be talking about people with innate variations of sex characteristics as well, and I'm actually not. So I'm sorry about that. I feel like I'm not the right person to do that, so I'm not doing that. If the terminology gay, bisexual and other men who have sex with men is annoying you, it's because they're different. And there was a point in time where epidemiologists decided, well, first of all, gay men was being used, and then people came and talked about different cultural contexts and said all men who have sex with men aren't gay men. Epidemiologists thought, great, let's just call everybody men who have sex with men. And then gay men came and said, well, actually, that is completely erasing our social and political existence. So don't do it. So I don't. So I'm going to be using that term. Sorry if it's annoying. I'm going to be talking about the history of donation deferrals in relation to epidemiology, some challenges to the deferrals, and the new policies that are coming in, the plasma pathway, which has come in, and the gender neutral assessment, which is due to come in sometime in 2026. And again, there's that question, how do we ensure that decisions are fair and equitable, and dare I say, evidence-based, while ensuring blood safety? By the end of this, I think you'll agree that the evidence-based is not the key thing, much more about values. And I'm focusing on HIV because HIV has been the focus of my career. I've been working in HIV since 1994. And so that's the prism through which I see this. If afterwards you want to talk about other kinds of deferrals, I do, because I work with Lifeblood, I do know about those and can fill you. But this is kind of my expertise area. So critical point in that first point there on the slide is June 1981. That's when it was first reported that you were seeing this cluster of symptoms in gay men in the United States. Of course, we now know that AIDS and HIV had a much longer history than this, but this is where it was first seen. HIV itself as an etiological agent wasn't identified until 1983, and there was a huge furore about that as well, which I won't talk to you about. And the screening test wasn't developed actually until 1984 and implemented in 1985. Importantly, the first screening test for HIV looked for the presence of antibody. And it takes around about 3 months for antibody to develop. So there really was what was known as a window period. There was a period in which a person could have HIV, but they wouldn't test HIV positive on an antibody test. That was really important for blood donation. I want to talk to you a little bit about blood scandals. So this is the background to the deferrals. Look at that hideous, hideous headline. I've actually looked up the $10,000 fine. I can't find what exactly that was. Even Google AI didn't help on that. I'm sure John Caldor knows, but he's out of the country, as always. I'll be able to find out if anybody cares. I'll fill you in. So this was Australia in 1984. A gay man had donated blood. I'll talk to you a little bit later about the circumstances under which he donated blood, and a transfusion was given to 3 babies who died. This was one of the huge crises, one of those real points in Australia where, one of those real inflection points where things could have got very, very nasty. And luckily they didn't, because things were put in place that kind of controlled the anger in the community. The US, France, Canada, Japan, China, and the UK all had massive failures of regulation. Their failures of regulation went on much, much longer than Australia's did. They introduced their blood protection measures way too slowly, but I'll talk to you in detail about what Australia did. Some of you will have seen only last year that the UK issued a great big comprehensive report on the failures in their system and the resulting deaths of 30,000 people due to contaminated blood and blood products that could have been avoided. So it's really serious business. You know, it's very, very important that you have safe blood. Some of you will also know that China had a commercial plasma enterprise in the Henan province in the mid-90s, 91 to about 95, where an estimated 1.2 million people were acquired HIV. And they acquired HIV because they were doing paid plasma donation. And what they did was they just kind of pulled all those red blood cells together and reinfused them into people. The idea was that HIV was a kind of Westerners disease and nobody had it in China. And when you're doing stuff like that, you know, kind of only takes one. So it's a horrible, horrible tragedy that what happened in China then. But recently 12,000 units of plasma products were recalled. So that was just 6 years ago in China. So there's been ongoing issues in the blood supply in China. So I'm going to use the annoying acronym. I'm sorry, I'll try to remember to say it out loud. Transfusion transmissible infections. The most recent cases of transfusion transmissible infections in blood recipients in Australia were 2011 for hepatitis B, 1999 for HIV, and 1991 for hepatitis C. The 1999 one, the first one that I want to talk about, I was actually the media manager for the Australian Federation of AIDS organisations at the time. And this was when the blood service was still using Western blot and ELISA double testing for HIV of all blood. So all blood was being tested like that, but they weren't using nucleic acid testing, which was available. One of the things that I had to do in my role was to, talk about, how this was kind of unavoidable and how it would be too expensive and all that kind of stuff to implement nucleic acid testing, which immediately in 2000 got implemented. Mm. So in some ways, I feel like, as a representative of a community organisation, was in that position of, talking the talk when actually it shouldn't have happened. The circumstances in which it happened, it was a regular blood donor. It was a woman. There was great relief in the community, in the gay community at the time in Sydney and Sydney and Melbourne, that was not a gay man. She was a regular blood donor. She had a new sex partner. She had not considered the chance of HIV. She wasn't asked a question that would screen that out. The tragedy in this was it was a young girl who acquired HIV in this way. Her father was in the medical profession, and he had actually said prior to her going into surgery, can we, do an autologous, can we do a donation, a directed donation for her? And The family was told, no, we don't do that. That's not Australian policy. Then this happened. At least it was 1999. This means that this young woman will have lived. She will have had access to therapy all her life. However, a pretty shocking thing. And so after that, Australia introduced the nucleic acid testing. I'm flipping back now to the 1980s. In the 1980s, even before the HIV test was developed, legal plaintiffs argued that people who inject drugs in their partners and gay men and other men who have sex with men should have been stopped from donating as early as 1982. And there are also legal arguments that there should have been different forms of screening in the blood, even though HIV screening wasn't available. Interestingly, in 1982, the New South Wales Blood Transfusion Service advertised in the biggest gay paper in Australia for gay men to donate blood. So this is where you're getting those mixed messages. This is a year after we know about it. In May 1983, there was deferral advice to key population groups, and how that was framed was promiscuous homosexual men were asked not to donate. Now, remember the Queensland babies, those 3 babies? The man who donated that blood, who was absolutely gutted, knew himself to not be a promiscuous gay man. So he had believed that it was perfect. So you can see how that offensive terminology in some ways led to a person misunderstanding his risk. By June 1983, it was asked that all sexually active gay bisexual men with multiple partners injecting drug users and their partners don't donate blood using a self-selection process. And later that became firmed up from a self-selection process to something a little more realistic. However, in November 1984, there was still a call from the New South Wales Sperm Bank asking gay men to donate sperm. So interesting things, interesting failures. And as I've said, HIV testing was introduced in 1980. So in terms of deferrals, in 1984, we saw the first one for all Australian jurisdictions. So at that stage, the blood service was jurisdictional. It later moved to be federal. In 2000, the next deferral was changed. Why was the deferral changed in 2000? Because of that nucleic acid testing. So once that came in, they changed the deferral to 12 months from last sex. And at this point, sex included included oral sex as well, which absolutely made no sense because oral sex is not a reasonable risk factor for HIV. And also 12 months, as we'll see, also made no sense. 12 months is not related to anything real. It's a period of time. You can make reasonable arguments for 3 months and 6 months. There's not a single argument you can make for 12 months. Plus, Australia's great big survey on sex, health and society shows us that anybody who's sexually active usually has sex within 12 months. That's something like over 90% of people. I have checked this. So say the 12-month deferral basically means that no sexually active gay men don't, even though it was less than that. In 2012, a review recommended changing the deferral period to 6 months. And that was based on, and there was evidence that justified this. It's kind of funny, wonky evidence, because the longest window period that's in there is actually for hepatitis C. And the risk management process that the blood bank used for that is you take the longest window period of all of the transfusion transmissible infections and you double it. But doubling it is a little bit, but that's what the recommendation of 6 months was based on. That was refused by the TGA because at that time HIV infections were increasing in Australia. So that's a really value-laden thing because this would not have made HIV infections increase in the blood supply, but the idea that HIV infections are increasing and we're going to change things for gay men in the blood supply was, not acceptable. And in 2021, the deferral was finally reduced to 3 months, which makes some kind of sense. It's defensible by the sort of logic of extreme precautionary risk avoidance that the blood bank uses. So again, it's basically the window period for hepatitis C. The window period for HIV using nucleic acid testing is about a week. So it's no longer really related to HIV there, which is interesting because it's HIV that's the big risk for gay, bisexual, and other men who have sex. As you would all know, there have been massive challenges to the deferrals, a really specific one from an individual, but advocacy groups have been challenging these deferrals for a long time. The point down the bottom there is that today, the most recent data that we have on HIV acquisition in Australia is that male-to-male sex remains the highest risk factor for HIV. So it's more than double that in heterosexual exposure. So the proportion has changed in that it used to be more, initially it was around about 80% of exposures for gay men. That dropped down to about 75, 70. It's now, only, they're getting closer. And that's because of the pill that prevents HIV in gay men, PrEP. Well, prevents it in everybody, mostly only gay men and other men who have had sex with men use it. So these are challenges to the deferrals. I also wanted to let you know what the 4-step safety strategy is for all blood collection. So firstly, there's the pre-donation education. Then there's the screening. So this is the interview that people do. Following that, all donated blood is tested for transfusion transmissible infections. And then there's pathogen inactivation. And that is particularly that's effective in plasma products. Now I'm going to talk to you about the deferral of trans and gender diverse people. From 2018, Lifeblood introduced a new question for trans and gender diverse people. If they had a sex partner who was male, trans or gender diverse in the last 3 months, they'd be deferred from donating for 3 months. So effectively, same kind of restriction as for gay, bisexual and other men who have sex. And there is evidence, particularly that trans women are having sex in a similar kind of pool to gay and other men who have sex with men. But there's a range of problems with the question. It's only asked of people who are known to be trans and gender diverse. So every person isn't asked that. And it could inadvertently defer people with negligible risk. So it applies to reported female at birth people who are having sex with other reported female at birth people who are one of the lowest risk groups, in terms of sexual exposure. Anyway, because it's using that term, trans and gender diverse. And the focus on identity actually means that a person could be having sex. And in our research, we had people who had this experience, who had the same sex partner for, many, many years, who were suddenly ineligible because their sex partner, who was the same person, identified as trans or gender diverse. And we all know that gender identity changes over a lifetime. So this was an ineffective set of questions, shall we say. We now have new approaches, the plasma pathway and gender neutral assessment. So it's the new dawn. Oh, sorry, I've gone backwards. So plasma for fractionation, and this is currently available. There's now no deferral for most sexual activities. So gay, bisexual, men who have sex with men can donate plasma for fractionation. There's also plasma that's used directly, which is different, regardless of when they had sex. And this includes people who are on the HIV prevention pill PrEP.
Could you explain fractionation?
Fractionation is where it's manufactured into different blood products. So it's when plasma is used in a whole lot of ways. It's basically split up into its parts and used, as distinct from if someone is getting a direct transfusion of plasma that has super high safety things attached to it. Most plasma is plasma for fractionation. And when you're giving it, there's no discussion about that. You're just categorised. If you're a person living with HIV or a sexual partner, which makes sense, if you're living with HIV, you can't donate blood. If you're a sexual partner of a person with HIV, you'll be deferred for 3 months. There's no evidence for this risk. In fact, Most people with HIV in Australia are on completely suppressive therapy, which means they cannot transmit it to a sexual partner. Many of their sexual partners, regardless of that, are people taking PrEP. So this is again, this is a risk factor that makes no sense in terms of the evidence. A risk factor, it's a deferral factor, sorry. And the big question here is, why has this not been introduced earlier? Because nothing has changed. There's been no technological change here. But this is something that could certainly have been in the blood donation kind of algorithm since about 2000, but it hasn't been. And again, and I've raised the question about the partners, sex partners of people with HIV. It's kind of frankly discriminatory that those people are deferred where other people, so a person on PrEP presumably imagines that they may have sex with somebody with HIV. But if you know that you're having sex with somebody with HIV, you're deferred. So the gender neutral assessment. This is coming in 2026, and Google AI tells me that one of the reasons that it's not in yet is that there's jurisdictional legislative stuff that has to happen. But it's been passed by the TGA, so it's going to happen. What that means is that all people are asked the same questions, irrespective of gender. So everyone is asked if they've had sex with a new partner in the last 6 months. Everyone is asked if they've had sex with more than one partner in the last 6 months. And if they answer yes to each, they're then asked the big question, which is, have you had anal sex? And if the answer is yes to this, they're deferred for 6 months. So everybody gets asked that same set of questions. And the features of the new assessment: sex also means penetrative sex, doesn't include oral sex. That's a huge step forward. That's really, really important because that's evidence-based. The new regime also recognises that anal sex with a partner of unknown HIV status is the riskiest sexual activity. That's fantastic. That's true, and that's based in evidence. But it no longer recognises that this risk is in relation to HIV prevalence in a population. So it's not just what you do, it's the pool of people in which you do it that adds up to risk. That is the kind of thing that we as people working in community organisations, we're constantly telling our people who are coming to us and saying, why do these deferrals exist? And we would be advancing, the rationale around the evidence. So this regime seems really likely to defer some people at lower risk of HIV. For example, heterosexual people who say yes to the anal sex question and who don't have a partner who's from a high prevalence setting or has had sex with other men, and accept blood donations from people who are at higher risk. And presumably, this will get found in the testing. So I would expect that you'll start to see HIV infections going up. The 4-step safety process should mean that that is okay. However, the fact that HIV prevalence overall, actually incidence overall in Australia is going down might make a difference. But the big questions to me in having this reflection is, why have we had these changes now? Why did these changes not happen in 2000 when we had the biggest technological change in terms of the way that that blood was being processed? And if that didn't happen in 2000, well, you can see that possibly the fact that, a year earlier there had been an infection. Why not in 2012 when that review happened? That review that was asking for a pretty conservative 6 months. And I guess, and the final question is, why have we ended up with something that has prioritised being gender neutral over being a little bit closer to what the actual risks are and asking some more detailed questions? We know that there are large populations of gay men and other men who have sex with men and bisexual men who have extraordinarily low risk factors for HIV. We also know that there are some who have much higher ones, but everybody is being put, well, the screening questions are there, and the questions that are in place would have caught that infection in 1999, and that's important. So the woman who donated would have been asked if she had a new sexual partner. She answered yes, she would have been deferred. And so that wouldn't have happened. So and that's the end of my presentation. I'd now like to open this up to you. I mean, to me, what this is showing is how important values and politics have been in the way that these deferrals have gone. And despite so many people, including myself, constantly talking about, the evidence, we can't do this, we can't do that, in the end, it feels like there's been this enormous sea change that is not related to what we had been told was absolutely critical in terms of risk management around the blood supply. So what do people think? Any thoughts? I mean, it's great that people are no longer having experience.
Thank you so much. I'll get started. Please let us answer. I mean, I'll just make a note of this. Who have the questions? Ainsley?
I'll start. I hope the online folks can hear me. There are microphones in the room. That was great, Bridget. Thank you so much. You hold the room whenever you speak. It's so great. My question is potentially a bit left of field. I just wanted to ask about the term deferral, because I mean it's kind of deferral, but it's so refusal. And for a lot of the behaviours that were deferred, they're ongoing behaviours. And so I just wanted to kind of ask you a bit about the etymology of the term, and if I'm using that word correctly, and how did it come to be termed a deferral rather than something else? And has your research picked up on that at all?
That's a great question, Ainsley. And I don't remember the term deferral being used in the 90s. I think that it came in later on when certainly from the time that you've got the 12-month deferral rather than and I think it replaced, certainly in the discourses that I see in published papers, you see words like ban initially, and they were lifetime bans, which now have been shifted in the language toward being deferral, but I don't think that that's what they were called then. So I think that it was around 2000 when you got that change, and that deferral was seen as, but also it's not just HIV, and so maybe that's been the language of the blood services all along with other. For example, if you go to donate blood and you've got a streaming cold, they say to you, "Thank you for coming. That's really excellent. Please come back. We're going to defer you until your nose stops running." That kind of. So that language has applied to other things that are less. And so possibly it was also used in blood collection contexts then, but certainly in other literature, the word ban was what was used. So great question.
Comment, but I'd like your thoughts on this. So in the beginning, you were speaking quickly. It just seemed to me a bit strange. Typically, when I think of equity, I'm thinking equity accessing something, accessing medication, accessing healthcare services, etc. But you're speaking equity to use something, or equity of eligibility. And it seemed to me, for me, strange use of the word. I'm wondering why you use that one. Perhaps to make justice would perhaps be more appropriate in that context rather than equity, but it's just a comment about that to me.
That's a really interesting point, Narcissus, and equity has been used by people who have been challenging equity and discrimination discourses have been used by people who are challenging blood donation deferrals. There's a body of research from around 2000 that the Centre for Social Research at UNSW did, particularly around hepatitis C, so it was in injected drug users, about some people know Titmus's work on the gift relationship, about donating blood as being a particular kind of identity and being a social identity that is kind of full of this kind of aura of goodness and being a good citizen, doing what you should do, being a generous, and the fact that social identity was not available to some people because of their member of a population group, particularly for men who have sex with men or gay men who weren't actually at increased risk. One of the big critiques was that the earlier way that just if you were a man who had sex with men, that you got deferred, regardless of whether that sex was a risk for HIV or not. And so that was the language that developed around that. There was a lot of discussion of rights when Michael Caine brought his case. It was all framed in rights language. And again, as a member of an HIV community organisation, we were very much on the front foot saying it is not a right to donate blood. However, there was this other research happening at the same time that was talking about how being prevented from donating blood was actually cutting off these social goods from people. And not just, I guess, it's a nice notion, social goods not being just something that you give, but something that you receive. Not just something that you receive, but something that you give. It's that in the wrong way. And so, that was a big critique of that.
Jane and Kate and Claire.
No, I did.
Yeah.
Well, this comment kind of follows on from that, just to pick up on the conversation, because something I was thinking about, so I have tattoos and have donated blood since I was about 18. Then, of course, I get deferred every time there's a new tattoo. I'm not exactly sure why, if it's HIV or hepatitis or what the concern is, but also for surgery. But so I was thinking about how that does not carry the same meaning. And there's something, and I think that this helps to justify why equity is the right term, because there's something, the way that the deferrals for blood products from these population groups, men who have sex with men and gay men, and now other people who have sex with trans or gender diverse people, it kind of connects into something like, I'm thinking about Deborah Luffen's work around disgust, like it connects into a squeamishness that has also been described amongst the HIV positive community of just people, like doctors not wanting to touch them. Things like, there's something about the way that we collectively think about blood and blood products that is deeply connected to the kind of stigma that community has carried for a while, I guess. Not even just as a result of HIV. I think that made it worse. It's already there. That doesn't connect to other reasons that you might get deferred or whatever.
That's a great point, Kate. And interestingly, the advocacy group Just Equal, their banner says, "Our blood is not risky." and so you see a lot of that kind of just, and also I think when you look at the 1 year deferral, that basically meant that any sexually active gay man or man who had sex with men was not going to be able to donate. And it may, there's nothing that you can do to the figures that gives you a year. It never made sense. But again, it's that idea that people didn't want sexually active gay men or men who had sex with men donating blood regardless. And that there's kind of blatant discrimination in that, I think. So, I mean, at the time, people thought it was better than what had been in place, but not really. So in some ways, it was another way of saying that the sex that you have is not okay.
Yeah.
There's just a pointer on following up on this. Is it like the 2026 one, which you were suggesting, right? It has moved away from the sexual identity towards the sexual practices, which also includes the larger heteronormative the groups, right? So, but you were asking this question, why now or why not before in 2000s or things? Is it because of the community organizations have been pushing, and then is there much more of a right space push from the community has changed the guideline? Do you see any connection?
I think that there must be. I think that there must be, and I think that's why a gender neutral assessment rather than a more nuanced one that still recognise there might be some epidemiological differences between particular population groups.
So
And also, I guess, but there's also a fine line, because some of the research that my PhD student Yasmin Mowat did was about how acceptable those questions are going to be. And so that is the other side of it, is that trying to narrow down and trying to make sure you're only asking the anal sex question to as limited a number of people as possible, so as not to frighten the horses, essentially. So there is that whole element of trying to please and trying to fit in with community norms. And I think it has become, so, I mean, in some way you could say that things like, marriage equality has maybe changed views enough to make it unacceptable to have in a deferral that's specifically applying to gay men and men who have sex with men, even if epidemiologically for a certain subset of that group that would be justified. And there is no doubt that that is the case. And it's relatively easy to do the kinds of things that you would need to do to just be addressing that group.
Well, I mean, maybe this is the conversation, right? Like, this is the thing that we're all fascinated by. Because I kept thinking, Bridget, about the 90s and how incredibly important it was for people to not be considered as dangerous. So for me, the equity was that lay in the perceptions of gay people as dangerous. And so it's not so much that it matters whether or not you can or can't donate blood per se, or that you can or can't be a giving person per se, although that's part of it. It was such a powerful point about the abject of all of those dying gay men as being worthy as anybody else of care. That was a huge component then, and not terrifying. It was so important to many people, not only gay people, that people with HIV weren't terrifying. And I really want to hang on to that point because it resurfaces so fast. And I instance COVID and hemorrhagic fevers, where, you really quickly have politicians saying, well, they're going to die anyway, we should just, kill them. And which literally was said when we had the Ebola outbreaks in 2014. No, you should just put them in a room that's hermetically sealed and leave them to it, because that's the right way to deal with that kind of threat. So that resumption of how important it is to think about the dangerousness of people, for me, that's where equity and justice lie. And I'd be really interested to hear you speak about that. And you know me, I'm always wanting to put things in context. So my other question actually is to invite you to reflect on what you gestured to at the very beginning of this talk, which is HIV in the context of all the other things. So the other big thing, when I think about blood donations, I think about mad cow disease, because that's what the 80s and blood donation was for me, as well as HIV. I actually don't know where that's ended up.
It's gone.
You don't have...
Mad cow disease hasn't gone, but there's no deferral around it anymore.
There's no deferral.
So and that went a couple of years ago. And it was, a big cause for celebration, and lots of people with English accents from my research institution were on the media, on the news channel, donating blood, having not been allowed to, that was a very, very interestingly couched deferral, because it applied to people who had been living in the UK in a particular period of time, regardless of whether they ate beef.
Yeah.
I find that kind of head spinning.
Risk parameters, it was a really interesting kind of comparative. But I actually wanted you to take that into thinking about this question of how nuanced you can make a rule.
Mm-hmm. And the argument around that was, it also depends on who's making them.
Yeah.
So you had lots of people sitting around the table saying, well, how are people going to know whether they ate meat or whether they ate beef or not? And it's like, there are a whole lot of people who are going to know whether they ate beef or not. There's a whole lot of people who will not eat beef religiously, and a whole lot of people who will not eat meat. And I think the fact that those people weren't part of those discussions is possibly one of the reasons that ended up looking the way that it did. But also that the lessons from the 1980s and, you know, the kind of cataclysmic things that happened in blood supplies did make blood services incredibly risk averse. And I mean, that's a good thing. It's a good thing for anybody who has received blood donations in Australia, that you could be pretty certain, apart from that appalling instance in 1999, that you're going to be getting safe life death. But it does look like that since 2000, there were other ways to do it. So in many ways, my critique of what's happening now is not so much what's happening now, but why it didn't happen. And I think perhaps that what Supriya said might be the kind of key to it, that community values have changed so much, and that we are more prepared to say that we are not going to just have this sort of blanket population deferrals that actually bear no relationship to the individual, you know, who's sitting there saying, I want to donate blood. There was also the Orlando nightclub, and that was a sort of really kind of moving story about, I don't know if people remember it, was in the late 2010s, where there was a terrorist event in a gay nightclub in Orlando in the United States. And there was this big response of people just going out to donate blood, and of course the whole world got it. The US and Australia don't have the same rules, but they have similar rules. And at that time, they also had 12-month deferrals as Australia.
Morgan, Jane, and Kat.
Hi, Bridget. I'm so sorry I'm late, and I flew in this morning and my flight was delayed.
Oh.
So I don't know if you've addressed this issue already. You might have done at the beginning of the talk. But people with innate variations of sex characteristics were enmeshed into this discussion about gender, sexuality, and biases. Why do you think that is, and what do you think can be done about that enmeshment?
And I actually haven't talked about that, Morgan, so I'm glad that you've brought it up. And I haven't talked about it because I felt I looked at what Lifeblood has on its website, and what it says is, if there's a question, you know, I'm intersex, can I donate? And it says, yes, you can donate. There's nothing that says if you're intersex that you can't donate. And then it just says stuff about gender. So again, that kind of arguably reinforces ideas about intersex as being all about gender, and doesn't, it's not a terribly useful kind of, but I guess my theory would be that's why intersex people or intersex as a concept gets caught up in this, that people see it as being somehow similar to trans. And as I talked about, there's been questions around trans identity were really not helpful and really annoying to people who were regular blood donors who were suddenly told that in the context of having the same relationship, they suddenly couldn't donate because of the identity of their identity as distinct from risk profile or anything else. So all of these things together is kind of getting mixed up. I feel like there's a lot of things together getting mixed up in the way that deferrals have worked, Morgan. Would you like to say more about that? What's your experience?
Well, I've never donated blood, both because I'm a guy who sometimes has relationships with other men, but also because I lived in the UK for a part of the period. It's not a disease is an issue. So I've got no experience on it. I guess I will do at some point. Yeah, look, I think, but the enmeshment generally is a collapsing of multiple different populations into very simplistic ideas about sexuality and gender, which are often not a very good fit with people's lived experience and lived reality.
Yeah.
Jane and Kat.
Yeah, thanks, Bridget. It's so interesting. I was thinking about nuance, which is something that Claire raised, and you know, at the beginning, sort of early on in the history, you had that thing about, you know, promiscuous gay men weren't allowed to donate, which is obviously an offensive and clumsy. Well, you know, but what it is though is a way of trying to assess risk in ways that didn't happen subsequently. Right? So I'm kind of interested in the way that it was really blunt and risk focused, inappropriate, and then moved into these huge generalities, and then also captured people who were very, very low risk. And then, like, is there a point where we just need to be really explicit about who particularly is really high risk, or is that bad?
I think that that's a good point, Jane. And I think that when you still had the 3-month window period before, so when there really was up to 3 months before you could detect HIV in a blood donation, that the need to be incredibly risk averse was very, very, I mean, you know, it was critically, was, you know, the safety of the blood supply or the reliability of it kind of dependent on that. This 3 months is, it's too big. You can't think that anything is going to get, you know, caught at that second thing. Morgan, you would have missed this, but the man who donated the blood, that then, by which blood the 3 Queensland babies acquired HIV, donated because he'd seen the promiscuous gay men unable to donate, but he wasn't a promiscuous gay man. So, you know, and this was prior to HIV tests as well. So you can see how, you know, well-meaning, good-doing people can, you know, could make mistakes in that context when you had that 3-month window period. But I guess once that changed, arguably more things should have changed, because, you know, the people in the community would say, but I have been with the same partner for 5 years. And what the researchers would be saying, yes, but do you know that your partner has just been with you for 5 years? And, you know, so that those were the kinds of discourses that preserved the regime of these long deferrals for gay men and heterosexuals. This notion that, you know, you might be able to answer to your own behaviour, but if your sexual partners are from a particular population group, how can you answer to their behaviour? And arguably, again, while you had the 3-month window period, you can see that matters, because that level of blood safety needs to be as perfect as possible. But once you actually have that second level coming in, once you've got the effective testing, which you had since 2000, I think it changes things.
Thank you, Bridget, for your presentation. I have so many thoughts, but when I was listening to your presentation, I just felt that there was this discourse between, oh, there's this new thing that we didn't know about that's going to affect blood donation. And it kind of just reminded me of like a really drawn out and awkward coming out process of like the LGBTQI+ community coming out in ways, in violence, I guess, where, you know, our identities or behaviours are being overly scrutinised, and how autonomy in sharing that has occurred, but there seems to still be this kind of epistemic ignorance about acknowledging, you know, community needs, and I really appreciated your kind of inclusion of, you know, but what about us being good people? What about us, you know, being fully participating in a way that is valuable? And I think, you know, it's led to things like enmeshment, as Morgan articulated. So I'm just thinking about the systems as well as, you know, this small fry people in it trying to, you know, navigate it. And if you have anything to comment on about that.
That's an interesting point. And in some ways, when I reflect back on, as someone in a community organisation, you know, giving the spiel about you know, initially why we didn't have NAT testing and that was okay, when clearly it wasn't really okay. That was also trying to be a good person or trying to be good organisations who were being part of protecting the blood supply, which was part of protecting the blood supply's reputation. And, you know, explaining why a 6-month deferral made sense when that was, you know, taking the window period for hepatitis C and doubling it. Which, as I say it, it's a little bit odd. That was also, you know, there were notions of goodness being effective, not lunatic fringe organisations, but being organisations who were socially committed to the good for everybody. And certainly there was that sense, especially around that 1999 transition, that, you know, the collective kind of relief that it wasn't a gay man who made that donation was extraordinary. And it's hard to explain what that felt like when you found out that, you know, that there wasn't going to be this massive kind of wave of homophobia that came from that donation, but much more of a kind of, oh, you know, she was a good person who made a mistake.
Or didn't even, because she wasn't asked. She was a good person who.
Absolutely sure that she wasn't asked. If she was asked, she didn't occur to her. But yeah, I don't actually know exactly what the donor questionnaire said. 1990 would have been 1991. She did that. Yeah, nurses.
Just to follow up on, sorry.
And Cyprian.
Yeah, just okay, sorry, I missed that. No, the aspect of goodness is more of the sexual practices. The idea of goodness, the good person idea, which you were referring to. What was it reference to? Sorry, I missed, I guess.
Oh, in terms of being socially in supporting the blood service.
Okay,
in supporting the goals of the blood service and the importance of keeping blood safety, and recognising that very complicated sums had gone into what was what the deferral periods were, except that when you look at those, 12 months never made any sense. You know, there is no sum that looks at 12 months as a deferral period.
Also the same thing.
I was just going to comment about, just going to bring Mary Douglas into the conversation, because, you know, the risk for her is a forensic device that distributes blame and responsibility. So that's what it does. So that's why we were so relieved.
Yes,
Someone dangerous wasn't to blame.
yes, you're
We
right.
weren't going to be creating those categories of danger. And why
Someone not dangerous who would be perceived as dangerous, who would fit into that dangerous category, and who would reignite that kind of social violence.
punitive blame response, which is, for me, again, the grounds of judging what's fair.
Yeah, absolutely. Yeah.
And what if she got slut shamed and things like that? I can see this causing a different kind of blowback.
No one knows who she is.
Oh, really?
Yeah. Well, there will be some people who know who she is, but no one knows who she is. I wonder if that would have happened had it been a gay man. I wonder if that man would have been hunted down.
Like some people were during COVID, for
Yeah.
example.
Yeah, because it's interesting that the man whose blood resulted in the Queensland babies, that he did become known. Like, his name isn't there or anything, but if you read all around that, people knew who he was. We found out who he was. Do people know about the Sydney Blood Bank cohort as well, though? That's another fantastic, fascinating thing. There was this group of people whose infections were traced to a single donation. And there were this group of people with HIV who didn't get sick. And they didn't get sick for such a long time that, as you know, technology improved, they started to analyse their HIV, and they found that they had a wonky HIV strain. It didn't have a particular gene. It was called left gene deleted. And so a vaccine candidate started to be made using this. And just around the time that there was a whole lot of physicians around the world saying, yep, I'll participate in that study. People in the blood bank cohort started to experience immune decline. So it wasn't that the strain that they had didn't cause immune decline, it just did it at a much, much slower rate than normal. But it was fascinating, you know, and that was from, you know, tracing back to a particular donor and, you know, and watching these people. And of course, these people are, you know, alive and well and walking amongst us now on antiretrovirals, but because they didn't need antiretrovirals in the time when antiretrovirals didn't exist. It took such a long time, but yeah, not a good vaccine candidate. It's actually did cause disease eventually. But I know another one of those fascinating stories.
Anyone has any quick thought?
Question. So to what extent is the safety of the blood dependent people entering this questionnaire? So I'm guessing it seems like there's a great deal of trust being placed by individuals in the community. Well, great. That. Yeah, I'm just curious to know are there secondary technical processes in place to confirm?
Yes. So every donation is checked. And so arguably, and this has been explained, that the fact of the first screening, and so some blood collection services, so in places like you know, think about Eswatini, where people have where the actually prevalence is so high, they would probably be relying much more on the actual screening of the blood and dumping it. But because there's a potential for human error, that when you screen the blood, what if it accidentally goes into uncontaminated rather than contaminated? So that's another level of, you know, potential for error. So that's how risk averse it is. First of all, trying to eliminate all of the problems at who donates level, but then there's the testing level. And the idea is that you want the smallest number of, you know, you don't want blood with HIV in the blood collection centre because of the extraordinarily remote possibility that somehow it goes into the wrong batch because human error can happen. So yeah, so that's how that works. And I guess it's important. If you can.
I'm just wondering if the technology is advanced enough. Is it to save resources?
No, everyone is screened. It's about the human error at that point. So the potential for blood that has been found to be contaminated going in the wrong direction. So it's a very, very risk averse system. And because that screening is now good, you know, it's up to, but it's not perfect. It's not going to give you, if somebody doesn't answer honestly and you're in that 1 week period, there's a remote chance that nucleic acid.
Great. Thank you so much, Bridget, for joining us and for this excellent conversation.
Thank you. Thank you for having me.